This is Catherine Skefos, and she is from MD Anderson, and she is here to talk about hereditary non-medullary thyroid cancer and family communication about hereditary conditions.
Thank you for that introduction. I am a genetic counselor at MD Anderson, and I work specifically in the endocrine center. So I talk with a lot of patients who have thyroid cancer and other cancers about hereditary risk. And a big part of that conversation is family communication. And so we'll talk a little bit about, to start with, a sort of genetics 101 to make sure we're all on the same page when we know, or when we're talking about genetics and what does it mean to have a hereditary condition versus a familial condition and things like that. I'll talk about some different genetic syndromes that are associated with thyroid cancer, as well as an entity called familial thyroid cancer, which you'll see is slightly different. And then we'll talk through some topics about how to talk with family about hereditary risk. And I invite anyone to share as we go along if you have specific questions about your family, or if there's anything that you'd like to talk about specific to your family. I'm happy to do that. Just know that I think this session is being recorded. So just want to give people a heads up about that in case there's anything that they don't want to share to be recorded. So first of all, what do we need to know about genetics for this conversation? I'm going to talk to you guys like I would talk to my patients in clinic to give that sort of genetics 101. So we all are born with over 20,000 genes in every single cell of our body. Our genes are the instruction manuals for how our bodies grow and develop. So we, of course, have genes related to our eye color and our hair color and perhaps which parent we're going to look more like. But for our purposes, we are most interested in a set of genes whose job it is to protect us from developing cancers. And most cancers do not happen due to a hereditary factor. Most cancers happen more or less by chance or due to an environmental factor or something like that that we might be exposed to. Most of the time, we can't even quite pinpoint what that is. So we call those types of cancers sporadic cancers. Now, this is sort of a breakdown of the different parts or different aspects of genetics for us here. So in all of our body cells, we have our genetic information packed into chromosomes. We inherit one copy of each chromosome from our mom and one copy of each chromosome from our dad. Then we get the X chromosome from mom and the Y chromosome from dad. Within those chromosomes, our genetic information is packaged into genes. We can think about genes as the sentences or the books even in our chromosome library. Our genes provide those instructions to create proteins, and proteins are the little messengers within our body. So our hormones are proteins. There are proteins that tell our cells when it's time to grow and divide, and very importantly, when it's time to stop growing and dividing. And so one thing that we'll talk about today is how sometimes if there is a difference or what we call a mutation in a particular gene, its protein may not function how it's supposed to function. And that's when we can see a hereditary cancer risk developing. As I mentioned, most thyroid cancers, really a vast majority of thyroid cancers, fall into the category of sporadic or happening by chance. Oh, I don't know why that changed, but that's okay. We think about sporadic cancers as happening due to acquired gene mutations that happen just right there in the thyroid that cause those cells to turn into cancer. That might be influenced by things like environmental factors, but we often can't quite pinpoint that. And if there's a single or perhaps two cases of a thyroid cancer in a family, we would say that that most likely falls into that sporadic category. Familial thyroid cancers make up about 5% of all thyroid cancers. And that we can define, oh, I'm so sorry, there's a typo there. It should say a cluster of thyroid cancer in a family without a single identifiable gene mutation. We think about defining familial thyroid cancers as when there are 3 or more thyroid cancers among first-degree relatives. So thinking about a patient who has thyroid cancer, if their sibling and their child or their parent and their child all have thyroid cancer, that can be defined as familial thyroid cancer. Hereditary thyroid cancer makes up around 5% or less of all thyroid cancers. And in those cases, we can find an identifiable single gene mutation that leads to specific patterns of cancer in a family. Now, some of you may have had testing done on your thyroid cancer, which is called somatic testing. This is different from what we're talking about today, which is also called germline testing. The difference between the two is finding out the answer to the question of, was this person born with a genetic difference that caused their thyroid cancer, or did they acquire that genetic difference over time just right there in the thyroid? So somatic testing is done on tumor tissue, whereas germline testing is done on healthy tissue. That typically is blood or saliva, but in some cases, we might need to do a skin punch biopsy. For example, if someone has an active leukemia or something like that, we would need to find a different healthy tissue other than the blood. If a mutation is found to be germline or hereditary, that gives some really important information about future cancer risk, as well as risk for family members. So some of you may have met with a genetic counselor in the past, but if not, I just wanted to tell you a little bit about what I do in clinic. So genetic counseling is the process of helping people understand and adapt to a genetic diagnosis. And so part of my job is to interpret family history and medical history to determine what the chances are of there being some sort of hereditary factor at play. I educate patients about inheritance patterns, about testing options. What would your plan look like if you tested positive for something versus what would it look like if your testing came back normal? And then providing counseling to promote informed choices about making decisions about testing and to adapt to any hereditary risk that may be uncovered. So as part of that appointment, I take a thorough family history and medical history, talk through what type of testing is indicated, and help a patient come to a decision about whether or not to do genetic testing. And a big part of that as well is informed consent, making sure that patients know what the potential outcomes are. In terms of taking a family history, there are certain things that I look for in a family history, aside from thyroid cancer, to help determine what type of testing is indicated. So sometimes people with thyroid cancer are referred to genetics if they have a strong family history of cancer, if there's a family history of things like ovarian, pancreatic, or early onset cancers like breast or colon cancer happening at the age of 50 or below. Sometimes a patient will be referred if they themselves have had multiple types of cancer, such as thyroid and breast cancer, for example. Now, when we think about a family history of cancer, for many of us, what might come to mind is a grandfather who had lung cancer or a grandmother who had bladder cancer, things like that. So there are certain types of cancers that are less concerning from a hereditary standpoint. And those tend to be cancers that occur a bit later in life or may have stronger ties to certain environmental exposures like exposures in the workplace or cigarette smoke exposure and things like that. With the informed consent process, I want to make sure that patients understand the purpose of testing, some of the limitations, mainly that we just don't know everything there is to know about genetics. And so a negative result today doesn't guarantee that there is no hereditary factor at play. We also talk about risks of genetic testing, including genetic discrimination, which I'll talk about in just a moment, the potential for unexpected findings, any concerns a patient might have about privacy or data usage, different things like that. So a common question that I get is, can my genetic information be used against me in any way? So I do like to always let people know about a law called the Genetic Information Non-Discrimination Act, which passed in 2008. And this is a law that provides protections against discrimination in two main areas, two very important areas. One is employment. So employers who have more than 15 employees are not allowed to discriminate on the basis of genetic information, meaning that they cannot elicit your genetic information for the purposes of hiring or firing or determining your compensation or anything like that. Importantly, this law does not apply to the military. So anyone in the military may be sort of governed by different rules. And then GINA also, and that's the acronym we use because the name of the law is a bit of a mouthful. So GINA also applies to health insurance, meaning that health insurance companies are not allowed to discriminate on the basis of genetic information. So we are very glad that these protections do exist, but there are some limitations. This law does not apply to things like long-term care insurance, life insurance, or disability insurance. So for some people, knowing that that is a possibility that those companies may ask them about genetic testing results may have an influence on whether or not they decide to undergo genetic testing. In terms of the logistics of testing, it typically, like I said, is done through saliva or blood, which are equally accurate. The turnaround time can be around 3 weeks or so, sometimes longer. And then often if a person meets insurance criteria, that insurance company will cover the cost of genetic testing. But of course, that doesn't always happen. Some labs will have a self-pay price of around $200 to $300. And some labs also offer patient assistance programs to make testing as affordable as possible. With results, we usually can talk about 3 different types of results. A positive result, meaning we found a hereditary factor in the family that's causing an increased risk of cancer. We can have a negative result, which means that no hereditary factor was found. And then we can have a third type of result called an uncertain result, which happens when the lab comes across a small difference that they just have not seen often enough to know. Does this explain the cancer in the family, or is this just a harmless difference that makes this person unique, but isn't actually impacting their risk at all? If we get that type of uncertain result, we're usually pretty reassuring. We usually say it's most likely that this is just something that makes you unique, but is not impacting your risk. So let's talk in a little bit more detail about specific hereditary conditions where we can see an increased risk of thyroid cancer. The first one that I'd like to talk about is a condition that sort of has 2 names. It used to be known as Cowden syndrome and is now more often referred to as P10 hamartoma tumor syndrome, which again, a bit of a mouthful. It's caused by genetic differences or mutations in a gene called P10. I also meant to say that you may hear the word mutations, you may hear a word like pathogenic variant, which just means a harmful difference in a gene. There are several different ways to call the same idea. So these are caused by mutations or differences in that P10 gene that cause the P10 gene not to work how it's supposed to. In families with Cowden syndrome, we typically see several different types of cancers, including breast, which is the highest risk for folks with Cowden syndrome. We can see thyroid cancer, endometrial or uterine cancer, as well as kidney cancers. But we also tend to see these specific skin findings. We can see these little white bumps on the skin. We can see colon polyps of a very specific pathology. We can see these little spots on the palms of the feet or palms of the hands or soles of the feet. And then we can see these growths on the mucosa or the mucous membranes. We also, in this particular condition, can see family members who have autism or developmental delay sometimes. And we also tend to see a larger than average head size, which is one of the hallmark features of this condition. Thyroid cancer risk in Cowden syndrome is estimated to be up to 38%, but different studies show different risk estimates. Follicular thyroid cancer is overrepresented, meaning more common among people with Cowden syndrome, although papillary thyroid cancer is still the most common type of thyroid cancer that folks with Cowden syndrome have. And thyroid nodules and cancers can occur in childhood. And so this is a condition where we will sometimes consider testing for this if a child is diagnosed with thyroid cancer. Another condition where we can see an increased risk of thyroid cancer is a condition that's called familial adenomatous polyposis, or FAP. This is a condition caused by genetic differences in a gene called APC. This is an inherited colon cancer syndrome predominantly, can cause a person to have many, many colon polyps, typically more than 20, but even into the thousands of colon polyps. Patients with this condition can also have extra teeth or missing teeth. We can also see certain rare types of tumors called desmoid tumors. With the thyroid cancer risk in FAP, we estimate up to about a 12% chance of a person developing thyroid cancer. And most of the thyroid cancer in FAP is the papillary type. There's one specific type of thyroid cancer that's very closely linked to FAP, which is called cribriform morular variant. And this is a rare type of thyroid cancer, but up to 50% of people with that type of thyroid cancer have this genetic condition. And so this is one specific reason for referral for genetic testing if someone has this specific subtype. An interesting thing about FAP is that almost a quarter of the cases represent what's called a de novo genetic difference, or a new genetic difference in a person that actually was not inherited from their mom or from their dad. The third condition I'd like to highlight is a condition that we have more recently discovered, just in the last maybe decade or so. It's called Dicer1 related tumor predisposition. The gene in this case is called Dicer1. And mainly the cancers and tumors that we see in people with this condition happen in early childhood. Several types of rare tumors, including pleuropulmonary blastoma, cystic nephroma, which is a tumor that happens in the kidney, and a certain type of rare ovarian and cervical cancers can be seen in this condition. And a majority of the cancer risk is expected to be before the age of 40. The more we learn about this condition, the more we realize that thyroid nodules and cancer may be some of the more common manifestations in a family. Up to 75% of women and 17% of men will develop thyroid nodules by age 40. And we don't have an exact number of what the risk of thyroid cancer is with this condition, but we do recommend thyroid screening for kids and adults with this condition. The last condition that I want to highlight is called Carney complex. Again, as you've seen sort of a pattern with the last three conditions, there are other major features of this that we might expect to see in a family that has this condition. We can see certain types of pigments on the skin that look sort of like very dark moles almost. We can also see certain rare types of tumors called myxomas and schwannomas. About when we see all of those features together that makes us think that someone has Carney complex, we can make a clinical diagnosis just based on the features that we see in an individual and their family. But about 80% of those folks will have a genetic difference found in this gene, PRKAR1A. Similar to FAP, a sizable proportion of these cases represent a new genetic difference in an individual, so we would not see a family history, and thyroid nodules are a very common feature of this condition. There are a few other hereditary syndromes where we can see an increased risk of thyroid cancer, including Li-Fraumeni syndrome, which is characterized more so by an increased risk of breast cancer and sarcomas, but we can certainly see thyroid cancer in those families. Werner syndrome, which is a very rare condition associated with premature aging, and possibly others that we either haven't yet discovered or that we just haven't quite characterized whether or not there may be an increased risk of thyroid cancer. One gene name that you may have come across if you have looked online about hereditary thyroid cancer risks is a gene called CHEK2. About 1% of the population is thought to have a genetic difference in this gene. So in the world of genetics, that's fairly common. We know that genetic differences in this gene cause an increased risk of breast cancer in women, but research has gone back and forth over the years as to whether or not people with this genetic difference do have an increased risk of thyroid cancer. Some studies have shown that there's a slight increased risk. Some studies have shown that there really is no increased risk. And so a recent study of a lot of individuals with a CHEK2 genetic difference have shown that maybe they have about a 1.5 times to 2.5 times chance of the general population of developing thyroid cancer. even though that was what we call a statistically significant finding, the question becomes, is that clinically significant to say that a person has twice the risk of developing thyroid cancer as an average person? That may not be enough of an increased risk to justify doing any screenings, but perhaps patients can be aware of, having their primary care doctor do physical exams and things like that, but perhaps no invasive or additional screening is needed. So at this time, we don't recommend any changes to a patient's thyroid management based on a CHEK2 genetic difference. We, if a person with a CHEK2 genetic difference has thyroid cancer, we can't quite say whether or not it contributed to that diagnosis or whether they just were, whether it was a coincidence, essentially. So since we've talked about those specific hereditary conditions related to thyroid cancer, I also want to touch on something that we call familial non-medullary thyroid cancer or familial papillary thyroid cancer. This is the case where we can definitely see more papillary thyroid cancers than we would expect to see in a family. If we see one or two cases, we could say that might be a coincidence that both of these people were diagnosed. But when we start seeing 3 or more cases, it becomes more of a pattern, and we can say that based on research, other family members also have an increased risk of developing thyroid cancer. So it seems in these families that there is what's called autosomal dominant inheritance. This is the same inheritance pattern as we would see with those previous 4 conditions that I described. What that means is that if a parent has it, there would be a 50% chance of inheriting that mutation from their, excuse me, let me restart that sentence. If a parent has that mutation, there would be a 50% chance of passing on that risk to their offspring. However, with this, we don't know if they're, what that exact risk looks like for offspring. We simply know that offspring and siblings seem to have a higher risk of thyroid cancer, high enough that it justifies some additional screening. In these families, we tend to see an equal number of men and women affected, which is different from when we just look at the statistics for thyroid cancer overall. And we may see things like earlier age of onset than average. But an important thing to note about these families is that we likely would not see any of those other cancer risks that we would expect to have seen in those previous conditions that I described. In terms of screening recommendations for unaffected family members, there is no specific national guidance for this, but there are some papers that suggest an annual physical exam with attention to a physical exam of the neck with a low threshold to follow up with ultrasound if any abnormalities are found. There currently is no clinically available genetic testing for non-syndromic familial thyroid cancer, but that's not for lack of trying. There are a lot of groups that are trying very, very hard to find what is it about these families that is causing them to develop this thyroid cancer. It's possible that it's what we call multifactorial, where there are several smaller genetic differences contributing, along with some environmental factors that might also be shared by a family. It's also possible that individual families have some sort of unique genetic difference that is unique to that family and is not present in larger, more population-based studies. It's possible that the inheritance is what we call polygenic, where there is not one single genetic factor, but instead multiple factors that interact with each other to cause that increased risk. It's a very difficult thing to study. And so we still have a lot to learn, but there are several studies that have identified some of these smaller or what we call low penetrance risk factors, where that risk factor alone might only impact the risk a little bit or by a small magnitude, but perhaps that in combination with other factors is what is explaining the thyroid cancer in a family. So I want to pause there before we go into more of the topic of family communication, just to see, are there any questions about what I've talked about so far? I feel like I went through it sort of quickly because I wanted to make sure we had time to discuss as a group. If anybody wants to share any information or ask any questions, now is a great time to do that. This microphone. Yeah, there are people joined online. So if you don't, is that okay?
I sort of missed the first, I'm sorry, but you gave some genetic things in the beginning and I missed those. But if your husband or my husband has thyroid cancer, could he pass on? So my daughter now has breast cancer. Is that something that could have happened that way?
So there are some genes that unite together breast and thyroid cancer from a hereditary perspective. Now, these are rare. So it's most likely that those probably both happened by chance, but I think a genetics evaluation is a good idea just to go through the whole family history and see if there is any indication for genetic testing.
Okay, so if I have my husband and I both have sisters that have breast cancer, but both were postmenopausal, so that wouldn't affect it, maybe.
That makes it less likely that there would be a hereditary cause. Now, there are some exceptions to that based on specific pathology of breast cancer. For example, triple negative breast cancer has a higher rate of being related to a hereditary cause.
Okay.
But in order to get the full picture, I think that an evaluation for your daughter would, be a fair idea.
So if she had genetic testing and they said she had no markers, then that would mean that there was nothing that, okay.
Most likely,
Okay.
yes.
We didn't understand that.
And those, of course, with the little asterisk that there may be something that we just don't know about right now. So we can really never say for 100% certainty that there was no hereditary risk involved. But what we can say is that it's very reassuring if the testing comes back normal, that there isn't anything we could pick up. Yeah. There's a question right there.
Okay, so I've had thyroid cancer, but I haven't had any genetic testing, right? And so the question is, should my kids, what should I do about my kids? And it seems like the end result of this is that if I did go through it and had some condition, then they would just get an annual neck exam or something. And if there were anything was felt, they would get an ultrasound. So why not just spare the expense of doing all the genetic testing and just have the annual neck exam? Anyway.
So first of all, there's nothing wrong with letting family members or asking family members to let their doctors know about the family history of cancer. I always think that's a great idea because then if anything does come up on a physical exam or symptom-wise, perhaps that doctor has that in mind, right? Like, this person has a family history of thyroid cancer. Maybe we should, investigate this, that sort of thing. So on the one hand, I always think that's a great idea. On the other hand, in terms of when we should consider doing genetic testing, for a vast majority of people with thyroid cancer, there really is no genetic testing indicated. But if you, as we were going through those different syndromes, if you were like, wait a minute, that kind of sounds like something that might be going on in my family, I do still recommend genetic testing, or at least, a genetic counseling appointment to see if testing is indicated, because there can be other risks associated. For example, with Cowden syndrome, that one that I talked about, we know that women with Cowden syndrome may have up to a 60% chance of developing breast cancer in their lifetime. So for those women, we would want them to start their mammograms and earlier in life, starting around age 25, rather than waiting until 40 or 45. And we'd want them to also have breast MRIs so that the breasts are being screened more often to try to catch something early if it were to develop. And so there are additional screening recommendations that would come if a genetic test comes back positive. Yeah.
I think there's a chance I could have Cowden syndrome. I would get tested for that. And if I do, then I would, if it came back positive, I would then have my kids tested for it.
Exactly.
And if they came back positive, they would get these extra screenings.
That's exactly right.
Okay.
Yeah.
I was trying to understand everything. So when you were speaking about germline and somatic, what is the BRAF test fall under somatic?
Yes, exactly. Yes. So BRAF testing, RAS, even RET testing for some patients, that can be done somatically as well. So yes, anything that's done on the tumor itself would be a somatic test. And with few exceptions, those are mutations that are limited to the thyroid. So we wouldn't need to then follow up and see, wait a minute, were they born with this BRAF mutation? We wouldn't be concerned about that.
My husband's been diagnosed with a BRAF, so that wouldn't have anything probably to do with our daughter. Then.
Right.
Okay.
Right. That represents a somatic difference that likely was just acquired. I didn't mean to say that likely was acquired over the lifetime rather than something that he was born with that increased his risk of cancer.
They think that he was X-rayed as a child.
Okay.
So they think that would have done it. So okay. Thank you.
So I also have a question about the BRAF. So I understand it's mostly just isolated to the tumor, but if you've tested positive for BRAF in different places of your body, like for example, I had a dermatology thing that tested positive for BRAF. How is that connected in any way? Because I did see like a study that connected thyroid cancer to melanoma with that BRAF connection. So how does that work if you end up having BRAF in multiple places?
That's a great question. So the tricky thing about BRAF is that it likes to be mutated in many different cancer types because it's a very powerful driver of a cancer developing. We would not expect it to be related from a hereditary point of view, except we may learn more in the future about some type of genetic difference that predisposes to BRAF mutated cancers. This is totally hypothetical. This is not something where you should go home and be like, hey, that genetic counselor that I talked to said that we're going to find something like this. This is more so like a question that I have. Will we one day discover that some people are more prone to have that particular gene as a genetic difference in their cancers? We don't have an answer to that right now. But as far as we know right now, there wouldn't be a specific relationship as to why you developed that BRAF mutation in a thyroid cancer and, you know, for instance, a melanoma or some other type of skin cancer. Thank you. Yeah, an excellent question.
Thank you. To confirm, you said a BRAF mutation, you are not born with it, you develop it?
That's right. Yes.
Is a first degree relative a parent, child, or sibling? Is that how you're defining it? So not a grandparent, not an aunt. No.
Second degree relative.
Gotcha.
Yeah. So it's I'm going to go back to that slide real quick because I do want to point something out. A patient with 2 or more first degree relatives. This is a somewhat arbitrary distinction, if you will. There is not a hard and fast rule that this is the only way to define this. So, for example, if you yourself have a mother and a grandmother, all with thyroid cancer, and you have thyroid cancer, that means that it's 2 first-degree relatives of your mother, at least. And so we would consider that falling under this umbrella. Does that make sense? How that's a little bit of a flexible definition depending on who we're exactly talking to.
Our families didn't have genetic testing. Should we tell our children about our BRAF, or is that because we were not born with it, then it wouldn't maybe not go to them?
That's a great question. So I still recommend that family members are aware of cancer diagnoses in the family and that they let their doctors know about that. But we wouldn't think there's any reason to do genetic testing for them specifically related to that BRAF.
Okay, thank you.
Could I ask a virtual question? I'm not sure if you can hear me or not.
We can hear you. Can you hear us?
Oh, great. Okay, yeah, I can. Yeah, just so I get in here. I had just kind of a general question. So I know our family is very unique. My husband has 3 mutations. They found a P10 mutation in the promoter region, which they've defined as a VUS variant of uncertain significance. And also more recently, we found that he has DICER1 as well as MUTYH, not the MAPs, just one allele that's not working correctly. So of that, my oldest daughter, who had thyroid cancer, has 2 of the 3. She has the P10 and the DICER1, and my youngest has all 3. My oldest
Mhm.
had follicular thyroid cancer when she was 10. My youngest, when she was 6, had a follicular adenoma when she was, again, when she was 6, didn't turn into cancer yet. And my husband had his thyroid removed, had several nodules, cysts, different things like that. I guess I have 2 questions. One would be, how do you know what mutation caused a thyroid cancer? And the second one would be, why do some family members with the exact same mutation get cancer and others do not?
That is an excellent question. So, in your family, it sounds like that dice, and please correct me if I'm wrong, but you
Mhm.
said the P10 was a variant of uncertain significance, but the dicer 1 is one of those pathogenic variants, or what we would call a mutation.
Yeah.
Is that right?
Correct. Yeah, we did the P10 mutation testing about 15, 16 years ago with
Mhm.
Dr. Ing, Cheris Ing in her lab at Cleveland
Mhm.
Clinic. So, and the other ones we did through Invitae a few years ago.
So it sounds like from what you're describing that it sounds like the dicer 1 is what we would say explains your family history, since for one, it sounds like that is tracking with the thyroid cancers in the family and the nodules. The other thing too is that, and unless you just left this part out, it doesn't sound like the family has any of those other features of the P10 syndrome that I described with Cowden syndrome.
The only thing they found on my husband is a couple of little bumps on his tongue, and that's it. He's had colonoscopies that have been clear, and he's 58. We don't have large head circumference. They don't have a lot of the skin manifestations. So yeah.
Yeah, and from what I know about the P10 gene, I believe, and this is getting a bit technical, but that's okay with me. The all of the variants that we know about in that promoter region of the P10 gene are still considered variants of uncertain significance,
Okay.
unless anything has changed in about a year since I specifically
Okay.
looked into that.
Okay.
So, with variants of uncertain significance, we usually treat them as innocent until proven guilty, because a lot of times they end up just representing harmless changes about us. And so it sounds like the dicer 1 is the more suspicious candidate here. And for relatives, we think about other screenings besides thyroid cancer screenings as well. We think about looking at the lungs and kidneys, depending on how old a person is. We also think about gynecologic screenings for women up to age 40.
Yep. The other
Could
thing in
also
the
be-
family we thought was suspicious was on my husband's side, he had an aunt that died of lung cancer at age 5.
Yeah.
So we
I
thought
think
dicer
that
1.
is
Yeah.
very, very compatible with dicer 1, unfortunately. Yeah, we can see it's rare, but we can see those early onset, early childhood cancers in some families.
And so why do some get cancer and some do not with the same exact mutation? Is that epigenetics, environmental?
Maybe we don't have a good answer for that. And I
Okay.
know this is like the $1 million question, because if we knew the answer to that, oh my goodness, we would do something about that.
Okay.
It's a common thing that we see with all hereditary predisposition syndromes, essentially, that people in the same family with the same exact genetic difference, someone can be 80 and have no manifestations at all. Or, with dicer 1, once we start looking, oh, maybe they have a thyroid nodule. And then you think, well, maybe they would have gotten a thyroid nodule anyway, even if they hadn't had this by the time they were 80. So
Right.
we do not have a good answer for that, unfortunately.
Okay. Okay. Well, thank you very much.
You're welcome. Thank you for sharing.
I saw that there was a mention of the SNPs there, and I'm wondering if that has anything to do with, other factors. Like, does that have any connection to having BRAF throughout your body? Like, is it from a SNP, or what things could it be coming from?
Yeah, so that was sort of what I was alluding to when I said maybe sometime in the future we'll discover that there could be some sort of predisposition to developing BRAF mutated cancers. For those of you that aren't familiar with that terminology, and I apologize that I didn't explain that, this right here, SNP, this stands for single nucleotide polymorphism. And this is the way that we describe genetic differences that are very, very common in the general population. So some of these conditions we see in 1 in 40,000 people or 1 in 10,000 people. But SNPs are things that we see in a sizable percentage of people. And they basically are a tiny little typo in a gene that you can't even really call a typo because the body still uses that gene just fine. It just may be slightly different. We think about these little common genetic differences as sometimes being representative of our ancestry. Perhaps they've just been passed down and down and down through the years and generations, and they don't cause any major health concerns. But we are learning more and more about their influence on cancer risk, especially in the world of breast cancer right now. That's the one area where it's sort of ready for prime time in terms of like having a clinical application. But I expect that we will learn more about those smaller genetic differences that may potentially add up when we think about having multiple of those genetic differences. So right now we don't know of anything related to that, specifically with thyroid cancer from like a clinical application perspective, but there's a lot of research going on from that perspective.
Is SNP something that you can talk to a genetic counselor about, or is it more so not? Like, how do you get that?
Yeah, so you can talk to us about it, but we're likely going to tell you that there isn't any clinical applicability of it right now. We are happy to talk about SNPs all day. It's a very interesting topic in our field, and something that is kind of a hot topic in many ways because we want to make sure that anything we're doing related to this, it's called a polygenic risk score, like looking at multiple small genetic differences to come up with a risk estimate. And it's used in breast cancer, but there are definite pros and cons and limitations of using that type of thing. So we can definitely talk about it, but there isn't any specific testing that we would offer at this point.
And lastly, I know the MTHFR is like a really common thing that I hear about in a lot of ThyCa meetings too. Does that have any connection whatsoever to cancer risk, or is that not so much?
I'm so glad you asked that. So research has gone back and forth over the years about whether or not MTHFR genetic variants are related to any really health concerns. And the current state of the research is that no major genetics or genetics adjacent organizations recommend any clinical testing for MTHFR because there is no clinical changes that we would recommend to anyone's care because there isn't any solid evidence that it is influencing health in any way. Yeah. Oh, thank you.
People online can hear you.
Okay. So my daughter had genetic testing. Would they necessarily have in the type for breast cancer? Would they have found the BRAF if she had it?
It's not typically a meaningful thing to test for with breast cancer.
So they wouldn't have tested her for that.
So
No.
it could have been included on her testing just depending on sort of what her treatment plan and everything looked like. There are some somatic tests that will automatically look at the BRAF gene for any genetic differences. From a germline or hereditary perspective, we typically think of things like the BRCA genes of being really meaningful in breast cancer. And then from a somatic perspective, they typically will look at things like estrogen and progesterone receptors, HER2 status, things like that to help determine the best way to treat a breast cancer.
Thank you.
Could I ask another question virtually? Would testing RNA along with the DNA provide any additional information?
That's a great question too. So RNA testing, I'm going to go back a slide or two actually because, oh, maybe I'm not.
I've heard it yields like an increase of like a 1 to 4% additional information or something along those lines.
Right. So I'm going to provide a little bit of extra context about this. So on that slide that I showed where it was the DNA and then there was an arrow and pointed to the protein, there's a step in between that, which is the RNA step. It's how our DNA gets translated into becoming a protein to send the signals in our blood and or in our bodies. And so sometimes it will sometimes, or more recently rather, we have the capability of testing that RNA product and of seeing, okay, based on what we know about the gene, we can guess what it's going to do to the protein. That's what we were doing for many years, is saying, okay, we know what this changes in the DNA, and we're making a albeit very, very educated guess, right, about what's going to go on with the protein. Now we're able to look at that intermediary step to see, okay, is the change that we were predicting from looking at the DNA, is that what's actually happening? We're getting a step closer to the protein to make sure that we're actually evaluating that genetic difference in an appropriate way. There have been some genetic differences that have been sort of proven one way or the other. They started off as an uncertain variant, or a variant of uncertain significance, and that RNA testing helped us to classify it. Oh, we are very reassured based on what we see on the RNA, so we're actually going to say that this is just a harmless difference. Or, ooh, that really changed that RNA, and so we know that that's therefore going to change that protein a lot. Then we might call that pathogenic or likely pathogenic. And just like you said on our virtual person, I'm so sorry, I didn't get your name. What's
That's
your name?
okay. Pam.
Pam. Okay, so just like Pam said, there has been a slightly increased risk of detecting or classifying a genetic finding based on that. Many places now offer RNA as their standard of care because of that, slight increase in finding a result that's meaningful for a patient, but it's not universally applied yet. So I would say that if there is a question about whether that would be relevant to you, the genetic testing lab is actually a great place to call. You can ask to speak to a genetic counselor there to say, hey, here is, perhaps the variant of uncertain significance that was found on my genetic testing. Do you think RNA testing would be beneficial in my case?
Okay, great. Thank you again.
You're welcome. Okay, we have about 15 minutes to talk about family communication, because I think this is, for me, one of the most important aspects of my job. Yes, the genetic testing is very important, but if we are not talking to our family about genetic testing results, then it sort of stops at the patient and does not fulfill its full potential as influencing the care of our family members, which is one of the main goals of genetic testing. So for the conditions that I talked about that have a specific genetic finding that we're able to identify on genetic testing, all first-degree relatives would have a 50% chance of sharing that same genetic difference. I can say up to a 50% chance because there are those conditions where sometimes a person is the first in their family to have that condition. A lot of family dynamics can come into play when thinking about discussing genetic findings and genetic risk with our family members. Thinking about things like estrangement. I haven't spoken with my sister in 2 years. How the heck am I supposed to broach that with this, new finding that just came up on my genetic testing report? Or my children are in elementary school or middle school or high school. How do I talk about this with them in a way that is meaningful but not scary? And then also thinking about family members who may not want testing, and thinking about, okay, well, I've told them and they haven't done anything with this information that I think is very important. What now? So I think, and then also, of course, thinking about feelings of guilt and anxiety that might come up with knowing that there's a hereditary risk in the family. Thinking about, how am I supposed to tell my kids that I may have passed something on to them that I didn't realize I was passing on? So the one major takeaway that I want to make sure people know is don't try to just navigate and handle all of this on your own. Talk to a trusted doctor, talk to a genetic counselor, talk to a therapist, help you work through all of these different aspects of family communication. This is a common topic when I'm in clinic and talking with patients who have a positive genetic test result. I like to sort of go through the family dynamics just a little bit. I'm not digging too much, but I'm asking, are you in contact with these folks? Do you think you could have a phone call with them? Or would you prefer a letter to send that might have all of that information in it ready to go? That way you don't have to come up with the words yourself, because that can be difficult to sort of come up with those words on your own and figure out how to talk with someone about that. In thinking about communicating with children, is this something that you should wait until they're 18 and have a sit down heart to heart about? Or is this something that you think you could maybe drop into everyday conversation when you're talking about why you're going to the doctor or why you have to have this checkup? We know our kids go to a doctor to have a checkup. Maybe you can talk to them a little bit about why mom goes to the doctor to have her checkups. And that can be done in an age appropriate way that doesn't have to be the whole conversation all at once, right? That's one of the main things that I tell patients. You do not need to communicate every single detail of this diagnosis to your 11-year-old in one sitting. That's okay. If maybe you start the conversation with talking about how, hey, you know how you and I have the same eye color? Crazy, right? That's genetics. There's the start of your conversation, and that can lead into other conversations. Hey, did you know that sometimes families can share health concerns too? Sometimes a lot of families will have, I don't know, like, did you hear about how your uncle has diabetes and so does grandmother? That can also happen with tumors or something like that. There are different ways to sort of introduce this into the conversation to sort of normalize it and make it less intimidating than thinking about having to have that whole conversation all at once. In thinking about guilt and anxiety with our genetic information, this is a totally normal reaction to have. It's also totally normal if you don't have that reaction. I sometimes broach the subject of this with patients and they go, are you crazy? I couldn't control what type of genetic information I passed down. I can't feel guilty about something I didn't have control over. And I say, fantastic, that's a great way to look at it. But that's not always the initial reaction. As parents, we never want to think about doing something that, or even if it was involuntary, that could have a negative impact on our kids. So in the moment, if anybody is ever feeling anxious or guilty about something that they pass down to their kid, I always like to remind them, think about the good things that you pass down to your kid. I know that sounds like such a silly reframing, but I do feel that in the moment that can be very helpful. Think about, she got her sense of humor from me, or she got her stubbornness from me, or she got her love of animals and music from me. Thinking about all of the good things that we also pass on to our kids can really help in the moment to reframe those feelings, and thinking about that risk. And the other way I also like to think about it is, in some ways, knowing this type of genetic information is really a gift, because there is a lot we don't know about our futures, for better or for worse, right? There's just a lot that we don't know. And in some ways, genetic testing can help give a window into how best to take care of yourself in the future. And that's not something that we all know. Many of us depend on population-based screening recommendations for when we're going to start our mammogram or a colonoscopy. And in some ways, it really is a gift to know that you're a person who needs to start those earlier than average. And what a powerful thing to know how to reduce the chances or catch a cancer early, or in some cases even prevent a cancer from developing. So that's also a helpful little reframe there in some cases. All right, I think that's about all I have for you all today. I am happy to stay and answer questions. Don't feel like you need to stay around if you want to take a break or anything like that, but I'm here.
May I ask a virtual question?
Yes, please.
Okay, I have Lynch syndrome, and thyroid cancer was my first cancer. And my mother also has Lynch syndrome, and thyroid cancer was her fourth cancer.
Oh, wow.
And her sister has Lynch syndrome, and I'm not sure which cancer thyroid cancer was for her, but it was one of her cancers. And I've noticed that same pattern with other family members who have tested, positive for the pathogenic mutation for Lynch syndrome that we have. Yeah. And the familial pattern of thyroid cancer in our family is only among the people who have Lynch syndrome. And I've only found one. I haven't looked in 5 years, but at the time that I was diagnosed with thyroid cancer, I found one European study that had shown certain Lynch syndrome variants, pathogenic variants, to be associated with thyroid cancer in just one study, but I haven't looked again. Are you aware of any research in that area? I know in the Lynch syndrome support groups, there are other families like mine.
Yeah, so my short answer is that no, I have not heard any updates in the last 5 years about a more, a stronger link or a more known link between Lynch syndrome and thyroid cancer. For those of you who haven't heard of Lynch syndrome, we typically think about it related to colon cancer, endometrial cancer, some other GI cancers, and ovarian cancer. But it is apparent that there are some families where thyroid cancer seems to track with the Lynch syndrome, and we don't have a good explanation yet as to why that is. And like you said, there could be a specific, what we call genotype phenotype, where a very specific genetic difference or misspelling within that gene related to Lynch syndrome may be more likely to develop thyroid cancer, and we don't know that yet still. I imagine that we will learn more about it in the future, and you may have seen that other Lynch syndrome guidelines in terms of screenings and things like that have become more tailored over time as we do learn more about the specific genes. But that link to thyroid cancer is still sort of elusive as far as I know.
Do you think that may be because they do not like when I was diagnosed with thyroid cancer and I said, oh, well, my mother had thyroid cancer and she has Lynch syndrome, and my aunt had thyroid cancer and she has Lynch syndrome. And I started talking to them, and I didn't know the other family history at the time, but I started talking to them about that. They still did not like test my tumor or test my thyroid cancer to see if it was Lynch syndrome related.
Yeah, I think that's such a great point, because you're exactly right. With Lynch syndrome, we have a test that we can do, a somatic test that shows us if it has features of Lynch syndrome. And that's not available for every hereditary predisposition, but we don't usually do that on thyroid cancers or even other, if someone is diagnosed with breast cancer and they have Lynch syndrome, we aren't typically doing that type of testing on the breast cancer. And so I think that that is definitely an avenue for future research and thinking, can we prove whether or not the Lynch syndrome was the driver of that cancer developing? An important question.
And breast cancer is another one of those that pops up among the people with Lynch syndrome in my family. So exactly. It just may be.
And on the one hand, we can say that population or cohort studies, so broader studies, are not showing a very specific or meaningful increased risk of breast or thyroid cancer, but that does not mean that in certain families or with certain mutations that there may be a meaningful risk. I might have said that a little bit backwards, but I think you got my drift on that one. That essentially to say we still have a lot to learn on a family or individual level about why certain people develop cancers. And this really goes back to that other question too, of because there are probably people in your family who may test positive who have not had a cancer or have had one instead of 3 cancers. And we still have a lot to learn about the why behind that.
Thank you.
Thank you for sharing that.
So are we relying on doctors to tell us when we should be genetic tested, or how do we know to put ourselves forward?
That's a great question. So sometimes, yes, sometimes a doctor will say, hey, this family history is suspicious. Let's get you over to either a genetic counselor or the doctor will order genetic testing for you. But sometimes people have to be their own advocates with this and say, I have this concern about my family history and I want to know more about what that risk might look like. And so I think that that's a very valid thing to bring to a doctor if you have concerns about family history. One thing I always tell people is a genetic counseling appointment does not have to mean genetic testing. Sometimes patients come to me because they're concerned about their family history. And I say, okay, I see what you're talking about, but because of X, Y, and Z, I actually don't have a concern for a hereditary cause. And I'm able to be sort of reassuring and say, everything that we see seems to sort of be in line with sporadic cancers and maybe no genetic testing is indicated. And it's okay. Sometimes people are like, oh, I'm sorry for wasting your time. It is not a waste of my time by any means. That is what we do. We evaluate family histories to see if any genetic testing is indicated. And so I am a big advocate for, asking your doctor if that's something that you're concerned about and getting a referral.
I have a question.
Oh, yeah.
So my father was diagnosed with papillary thyroid cancer in his 50s, and then I got diagnosed at 34 with papillary thyroid cancer. Mine tested positive for BRAF, but his didn't. So are you saying that's more likely coincidence versus genetic?
So I would say with 2 thyroid cancers in a family, if we don't see anything else suspicious, we would say that it's possible that this happened by chance and that maybe there was some sort of environmental factor that caused the thyroid cancer to develop. But it's the BRAF status doesn't necessarily make it more or less suspicious that there could be a hereditary, but typically have that family members threshold to, really categorize a family as having thyroid cancer.
Okay, thank you.
We had a doctor who told us that thyroid cancer was in 80% of the people, but it didn't manifest itself. Is that something that you?
So, yes, I don't know
There
the
you go.
exact number to say yes,
Yes,
80%,
he
but
just said that.
I do know that it can be a fairly common finding on autopsy that, if they go looking at the thyroid specifically, even if there are no symptoms or anything like that, that it can be a finding. Age is certainly one of our biggest risk factors for developing cancer in general. As we get older, our cells are sort of less able to regulate themselves as well as they're supposed to. And we've had a whole lifetime of accumulating possible environmental exposures or mutations that happen by chance and things like that. So in general, the older we get, the higher the chances of some type of cancer manifesting.
I'm just curious if getting diagnosed at a younger age has any other reason that there could be some other cause, because I know usually, like you said, cancer risk goes up as you age, but if you are diagnosed younger, does that mean you might be predisposed to other things?
Not as far as we know, unless there is one of those hereditary, like strictly hereditary syndromes in a family. So thyroid cancer is interesting in that it sort of has like an earlier onset than many other cancers like breast or colon cancer. So with breast and colon cancer, we think, okay, anybody under the age of 50 is considered early onset, but that's not the case with thyroid cancer. I would say that childhood onset is its own reason to consider genetic testing. But when we start looking at like the teens and early adulthood, most of those are happening by chance. And you're right, we don't typically have some sort of environmental factor that we can point to, especially for young people, because we haven't had a whole lot of time to be exposed to things. There are, of course, exceptions to that. But I think for the most part, young adults being diagnosed with thyroid cancer, we would say it usually is something that happened by chance.
And when you read that, like, once you have thyroid cancer, you're more likely to have another type, where they say, like, your risk of breast cancer or other types goes up by a certain percentage. Is that, so you're saying it's not really tied to anything, it's just kind of by chance?
I don't exactly know the answer to that. I don't know if those studies have accounted for any hereditary risk. That would be an important thing to look at with the studies. Another important thing to look at is specifically the magnitude of risk, because it's very different to say that there is a 10% increased risk, which kind of sounds substantial, versus saying there's a 3 times the risk of developing a cancer, or so all of those different things are important to look at anytime you're evaluating that type of study. But I can't speak more specifically to it. Thank you. Sorry.
I have 2 children in their 30s, and both of us have had papillary thyroid cancer, and their aunt, my wife's sister, also had papillary thyroid cancer. I'm the only one who has had any genetic testing, and I have CHEK2, oncogene, and Lynch syndrome. So I'm just wondering how urgent it is for my children in their 30s to undergo extra screening.
Have they had genetic testing done yet?
So we're talking about that.
Oh, okay, sure. So I think that they are at the right age to consider starting their screenings if they do test positive for something like Lynch syndrome. And so I think that the particular urgency really needs to be balanced with your comfort level in discussing that, because I think it's very important to sort of come, I don't know if come to terms is the right term that I'm looking for, but sort of adjust to that risk yourself, and then take some time to think about how to communicate that with them if that's something that's on your mind about telling them about this result and having them do their own testing. Typically for Lynch syndrome, the colonoscopy screening starts around age 25 to 30, depending on the particular gene. And then with CHEK2, we wouldn't think that that breast screening would be as urgent necessarily as the colonoscopy that specifically for Lynch syndrome. Does that answer your question?
Yes, that's kind of what I was getting at. But, and we're going to be looking into having them, if they wish, do the testing. What about screening for thyroid cancer? Is there any, with two parents and an aunt who have had papillary, do you think that they need extra screening for just thyroid cancer?
Sometimes we have to kind of take a family as a whole, despite what any sort of guidelines might tell us. And in that case, I think it's a good idea for them just to communicate that with their doctors, and let their doctors make that specific decision. I can tell you that there isn't any guidelines-based reason to suggest that they need extra thyroid screening, but physical exam of the neck is, an easy thing to incorporate into routine appointments. And so I think it's very reasonable for them to request that. Okay, thank you all so much for coming, and thank you all for your excellent questions and engagement with this.